So the question is, can you repair the Parkinsonian brain by transplanting new dopamine cells to replace it? And that's what I'm just going to talk about. And G-Force POGSIS is that global initiative to try and do that around a stem cell-derived dopamine cell. However, you have to remember that this therapy is not a cure. It will never cure Parkinson's disease because whatever causes Parkinson's disease will carry on. This is simply trying to repair a strategic part of the disease pathology. That's not to say you can make a massive, that's not to say you couldn't make a massive difference, but you're not curing it. And I think it's important because people use this term rather indiscriminately. So of course we're at Cure Parkinson's today, and that is actually getting rid of the disease. And that is obviously the ambition of all of us, but this is a place where we've started to at least try and improve aspects of the disease. So there are many different ways in which this have been attempted, and this history goes back to 1973, I think, so I learnt yesterday. So Anders Bjorklund, who's sitting at the back, is the person who invented this whole field. So during the 1970s, when I was at school, Anders was playing with rats and injecting dopamine cells into their brain and showing that they were actually having an effect. And in these animal studies, what it was shown was that if you knock out the dopamine cells and you transplant in dopamine cells, details of this is not critical, it worked. So if you took the developing dopamine cells out of the fetus, so out of a developing rat embryo, put them into the rat brain which had no dopamine cells, they could replace them, they made connections with the brain made connections with them, they released dopamine, and Mr. Ratty went back to normal. So based on all of that work, which was, if it started in 73, it was about 15 years till this then entered into the clinical arena. And what one knew from these animal studies was that if you transplant in fetal cells, they worked in this context. But could it be done in people with POGSIS? Would it work? Was it safe? And what would happen? So this began in the late 1980s. And a number of patients were done in Lund in Sweden, where Anders was working, and Marlin was at kindergarten at this point. I know you wouldn't, 87 you'd be at secondary school. Yeah. And what they demonstrated there, and I'm not going to go into huge details about this, was that early on in their trials, they discovered that some patients did extremely well. So there's a patient here, patient number 4, who was grafted, I think, in 1989, had fetal dopamine cells from aborted feces transplanted into the brain, and they went from being off 2/3 of the day, which, as you know, means that they basically, despite taking the best medical therapy at that time, for 2/3 of the day it looked as though it wasn't working. And then they had a transplant, and 3 years later, so in the early 90s, they now went from being off 2/3 of the day to off for none of the day, and they'd stopped all their medication. So clinically, this patient had behaved in a way that was very different to most people with POGSIS. They'd essentially got rid of the dopamine drugs and aspects of their disease. And on the scan done at the London at the Hammersmith Hospital, in the place where the cells were grafted, there was this slow growth of the dopamine cells. So this demonstrated that if you did the same procedure in people, the cells survived, they matured, they grew, and patients got better. Now, obviously, one of the problems was this patient didn't do as well as that patient, so it didn't work in everybody. But by the early 90s, people were really thinking this was a therapy that could go forward. So various centres took it on, including in the United States, where some patients had it, and then they died of unrelated causes. And then this paper appeared in the mid-1990s from Jeff Cordoa's group. And this was a patient who'd had a transplant. I think this was about 18 months after they'd had the transplant. There was some clinical improvement. There was improvement on the scan. But the important thing about this study was that when you looked in the brain of this patient who died for unrelated causes, you could see that all the cells had survived. And this orange around it is the fibers from the cells growing out into the brain. So it demonstrated by the mid-90s you could do it. It survived. It made some people better, and it made people better because when you looked at the transplant, it was actually surviving cells. Then the next, I would say, important piece of information about the success of this was a few years later, in that one patient who'd done extremely well, patient 4 from Sweden. He came back to the Hammersmith Hospital, and here they now did a slightly different study where they stimulated the transplant with a drug, with amphetamine, to see whether the transplant could release dopamine as the brain normally releases dopamine. And what they demonstrated was the transplant not only made the patient better, improved the scan, but when you stimulated the transplant, it released dopamine in the normal fashion. So it wasn't just sitting there releasing dopamine in an indiscriminate way, it was releasing it in a controlled way. So all of this was very encouraging, that everything was working well. And then in the early 1990s, in America, this was so, they were so excited by it, that they endeavoured to take it on with these so-called randomised double-blind placebo-controlled trials. So these are trials where people all go to, in this case, theatre to have surgery. So if we were doing this study now, you would all be in the study. Every single one of you would go to neurosurgery. You would have a hole drilled in your head and have a transplant. You would have a hole partially drilled through your head and have no transplant. And then depending on the trial, you'd either have, all of you would have immunosuppression, then somebody else would be assessing you. So none of you would know what treatment you'd had, whether you'd had the active treatment or not, and the person assessing you wouldn't know whether you'd had it or not. So that's why it's double blind. You're blinded, and the person assessing you is blinded. And that's to get rid of investigator bias and placebo, and is thought to be the best way by which to assess whether a therapy really works. And so the first of these trials was published in 2011, and this was the newspaper on that day. So this is a very rare example of a newspaper now, because on that page there is nothing about Brexit. Hard to believe that there was a day when there was not Brexit on the front page of the paper. But this was this miracle cure that I've just told you about, but of course we know it's not a cure. And it's not just gone badly, it's become catastrophic. So one of the things about newspapers is, I've said this before, some of you may have heard me say this, there's only two outcomes as far as a newspaper is concerned. It's either miraculous or catastrophic. You couldn't say new trial of Parkinson's cell therapy showed some efficacy but also had some worrying side effects, because that's not going to sell you papers. So this was the headline, and it was on this study which had appeared in 2001, and what they showed in this study was that using this similar approach, the patients were better, and some of them had developed side effects. And then in a second study that Jeff was involved with, which published 2 years later, is slightly different strategy, but similar process, no benefit, and side effects. So this created a big problem for the field. So in 2003, essentially, the field came to a standstill, because despite the success of the earlier patients in Sweden, some of which had come from the UK, these trials implied that it didn't work. So the question then arose, well, what can we do to understand this? And so what we decided, so Anders and myself, we had a conversation about this and decided that actually perhaps the sensible thing to do was, rather than just keep shouting at each other, was to sit down and try and work out what we actually knew and what we didn't know. So we set up a working group that met in 2006 for the first time up at the just outside the back of the Adam Brooks Hospital at the Brain Repair Centre. And then we had regular meetings over the next 3 years in London, which were funded by Parkinson's Disease Societies, they were called in those days, before they were rebranded to Parkinson's UK. And they funded the meetings, and we brought together people from all around the world who had worked on these trials, so we could try and get to the raw data and understand what it was that may have accounted for some of the differences we saw, and whether these could be solved and the field could move forward, or actually we knew the answer, it didn't really work, let's just stop now and move on to something else. And so what we did was we went through as much as we could through all the data, and we came up with what we thought were 4 key factors which seemed to influence whether people did well with this therapy or not. So even in these trials, there were some patients who did well, and similarly in the open label studies, which I was telling you previously, some of them didn't do well. So we tried to look at it and we thought, well, actually, it's something to do with the type of patients, how the tissue is prepared and put into the brain, how we stop the body from rejecting it through immunosuppression, and how long we follow people up. And so it was on the basis of all of that that we then started, through this working group, to come up with a design for a new trial, which is still ongoing. So we had all of these discussions. That led to us submitting a grant about how we could perhaps develop a new trial for this, which was funded by the European Union, which we extended twice, and is now in the sort of follow-up stage with generous funding from the Cure Parkinson's Trust. In fact, it's so generous that I've put them down twice to acknowledge their support. And at the moment, there are sort of 3 major groups who are still heavily involved with the prosecution of this trial. And this trial is called TransEuro. And this is a study, so this is an open label study. So this is a study where everyone knows what they're getting. I know what they're getting. They know what they're getting. And initially it was to sort of take it on and actually look at efficacy, but as it turned out, this proved not to be possible. So it actually turned more into a tolerability. How well do people tolerate this? How feasible is it to do this? And can we start to see whether we're actually getting better results? So we set all this up in 2010. We then embarked on the surgery in 2015, so it took us 5 years to get to graft the first patient because regulation and rules changed all the way along. We never ended up grafting as many patients as we wanted, and the last patient was grafted in 2018, so the trial will actually finish in 2021. So by the time we write the paper on this study, it will be 15 years from when we had the first meeting to discuss how to do it. So that gives you some idea of how long these things take. So what have we found to date? Well, to date, we would say of the 11 patients we've grafted, it's well tolerated. There hasn't been a lot of problems that we've seen with this intervention. It seems to have been well tolerated. The second thing we can say is it's not feasible. So this approach with fetal tissue, if you put the ethics to one side, it's obviously an ethically very controversial area. You have to collect tissue from 3 or 4 fetuses to graft one side of the brain. For the 21 surgeries we actually did over the course of 3 years, we had a further 87 surgeries which we cancelled at the last moment because we didn't have enough tissue. So you can imagine how popular this makes you up at Addenbrooke's when I tell them I want the whole of theatre cleared for Tuesday for a transplant, and 87 Tuesdays I tell them, don't bother, I haven't got enough tissue. So this could never become a feasible way forward. This was known before we did TransEuro. It was clear there was always going to be problems outside of the ethics with this. So there was always a need to look for another cell source, and the obvious cell source are stem cells, these cells that proliferate and then can be differentiated into what you want, which are dopamine cells. And when this project was set up in 2010, there was no protocols anywhere in the world that allowed you to take human stem cells and turn them into dopamine cells. So that's why, in many ways, we went for the fetal tissue. As it happened, Lorenz Studer, who's had to fly back, but Claire is here to talk on behalf of his group, and Marlin, together came up, well, not together, separately, but at the same time, with protocols that worked out how to do this. So early on in TransEuro, we already knew that the next generation of cells, which were going to be much more useful, stem cell-derived dopamine cells, were fast trundling towards clinic whilst we were labouring on with this TransEuro study. And this led us to think about how could we sensibly as a group take stem cell dopamine cells forward to the clinic in a way that didn't repeat all the mistakes we'd made in the past. So all of what I've told you about, how people didn't perhaps communicate in the best way, how we didn't think through all the issues. So this was set up in 2014, and we set about trying to invite people together who work on stem cell-derived dopamine cells for treating people with Parkinson's, with the express intention of trying to work out how we could best do that to take that to a clinical trial. So the groups that sort of came together, these are the sort of main groups that have worked together over the years. There have been lots of other people who've joined. So we have Jun from Japan, Lorenz and Vivian and their team from New York, TransEuro I've told you about, and Neurostem Cell Repair, which was a European consortium funded to do various bits of work, including a major bit around dopamine cells, which a lady in Milan led, Elena Catania, but Marlin took on really the leadership and the scientific direction for the dopamine cell-based therapies. We have Jeff from Chicago. Melissa is someone who worked out in California a lot on stem cells. Guangzhou and Su Chun, also from America. So we've invited and tried to include as many people as possible. And this year, for example, we had a group from China who joined us who've already gone into clinical trials with stem cells for Parkinson's disease. And the real idea of this was to not preclude people from coming. It was to be inclusive and to try and get everyone to work together to solve a common problem. And the problem was, how can we safely and efficiently and deliver stem cell-derived dopamine cells for people with Parkinson's disease? And what is extraordinary about this group is that people have taken on that challenge as a group whilst also doing their own individual work. So one of the great problems in science and clinical science is people tend to work in isolation. They want to show that they can do all of this. The great thing about this group is that everyone has come together to try and solve this problem together. And so this is the picture from last year. That's not the lecture theatre, I should say. That's a deliberate picture taken up a series of stairs rather than the lecture theatre where we were doing it all. And then there's four of us who sort of sit on this board to decide how best to take the group forward whilst listening to everybody within it. We've now met 6 times. So we met in London in 2014 on the very day that Cambridge United got promoted back into Division 2, so that was a big day for me. Then we went to New York, then we went to Chicago, Kyoto, Lund last year where that picture was taken, and we're here this year, and next year we'll be going back to New York. And so this is a bit of a crowded slide, but really the purpose of G-Force, which is where we've been for the last day and a half in the room next door, is to avoid the problems we'd seen in the past, to keep each other informed of where we're going. So everyone presents data that is not published. So this is all the very latest stuff, including all the problems. So if you ever go to a scientific meeting, no one's going to stand up and say, I wanted to make a dopamine cell for Parkinson's. Tell you what, I had this real problem. I couldn't get that to work. I couldn't get that to work. I then produced this, which looks like rubbish. Transplant, nothing happened. There we go, that's my talk. People always present, obviously, the complete story. And here, we hear about everything that works and doesn't work because we need to know what the problems are so we can start to solve them. So this common approach to solving it, and then this desire to try and use what we learn to help others as well. So as I say, we have updates, we have key issues, and then the final thing is that as I say, to try and communicate what we find, we try and use this as a platform to announce certain things or to suggest certain ways forward. So over the years, we've had a number of publications. So the first wasn't really anything we wrote. This was a short article that appeared in a very top medical journal called Nature. And this was important for us because it was written independently of us, but it was to say that cell therapies for Parkinson's disease may have a future. And it ought to advertise the fact that we'd actually got together to discuss how to do this, which was quite a major paradigm change for most people with experimental therapies. People, as I say, tend to work on their own rather than together. So this was thought to be an excellent way by which we as scientists and clinicians could get together and solve a problem together. We then sort of more formally discussed who we were in this article, which appeared in 2015, which sort of stated what we were really aiming to achieve with the hope that others in other fields would try and do the same. In 2016, we wrote an article which was, well, It's being filmed, so I better not say anything. So this was an article which was really to describe how we as a group saw the critical questions taking therapies forward. So what would be the questions we would like to be answered in the way we would like to answer them before we did a clinical trial, with the hope that people could look at some clinical trials that were appearing at this time and say, against your own standards, how does that compare? And they might find them wanting. So it was a slightly cryptic way of criticising some trials that were going on at that time. And then the year after, we published this paper in Cell Stem Cell, which really was which came out of the meeting that Jun kindly hosted in Kyoto, where we talked about how each group saw themselves developing a clinical trial with their own cells and the commonality in the way in which we could work together about that. And so, as I say, we met yesterday. We went through the whole day of we had a whole day of talks yesterday and today till 1:15. And what did we discover that was new? As I say, we've invited new members from China. So the idea, as I say, we will include anybody who's working around this particular area. It's obviously more difficult if it's a company, because one of the values of our meeting is we discuss everything in a very open way. And if you're a company, that's not what you tend to do. And also, we don't want to tell everyone everything, and that could be exploited against us. It's fair to say that trials have now started. So Jun, I'm sure he'll mention this, he did the first iPS dopamine cell transplant last year in a patient in Japan. A team in Harvard were presenting their data. The team from China were presenting their data. So these are now in the clinic, albeit in 1 or 2 patients in each case. We still recognise that there are issues about how we should better do these trials. So we still don't really know how to do these trials. We still don't know whether these therapies work, because they've only obviously just started going into patients. So you must be very wary when people tell you that these cell therapies work. And Jeff will be talking about that more this afternoon, because there's a whole area of stem cell tourism clinics around the world where people offer you cell-based therapies where they can treat anything. In this context, Parkinson's disease, for which there's no basis. And this is now a great excitement, but also brings with it its own challenges. So when we started doing Transuro and we transplanted our first patient in 2015, I think that the investment in cell-based therapies for Parkinson's disease worldwide was roughly in the region of about $0. When we grafted the last patient in March of last year, the amount of money going into cell-based therapies for Parkinson's disease in the sort of pharma, biotech area was in excess of $1 billion. I personally have no idea what happened between 2015 and 18 to completely change their view on this as a therapy, but it is, I would say, outside of vaccines and immune therapies against alpha-synuclein, I would say this is probably the hottest topic in Parkinson's disease for therapies in the pharma industry. So there's lots of big pharma involved with this. So I was going to stop at that point. I thought it was just useful to take you through cell-based therapies. What's the rationale for it to replace the dopamine cells? This is not a new field. You know, Anders has been working on it for many years. It went to clinical trials. There was lots of success. There was lots of hope. Then it sort of crashed. Now it's come back. And there's a lot of conflicting information you hear about it. But we set up G-Force, 5 years ago as a way of trying to work together to make this something which will make a difference to everybody in the best possible way that we can. And we've been very encouraging of people to join us, and we've been very encouraging of other fields of medicine that this might be something they could do as well to make sure that they can take their therapy forward at the right speed, in the right way, as safely and as effectively as possible. So I'm going to stop at this point, and then I think we've got various talks from the other groups, and then it's question and answer. Is that right?